have with us Dr. Pradip Kumar Bhattacharya, Professor and HOD and in charge Trauma Care, RIMS, Ranchi. And sir is the current president of ISCCM. A big round of applause to sir. Sir, I'll directly start with the questions regarding first the current challenges in ICU practices. What are the most common challenges ICU physicians face in managing carbapenem-resistant infections, and how have treatment approaches evolved in recent years?
Yeah, actually, it depends on the type of ICU where an expert is working. Suppose, because in India, you see there are different categories of ICUs. One at the private nursing home level, then those ICUs which are working at corporate level, then government tertiary care centers, and those apex bodies, they have a different ways, and those who are basically, although they call themselves as big hospitals, but when they refer the patients without any scientific approach of management, then things become more worse. So why I am saying this? Because I am working in a government tertiary care center. We have got a high level ICU, tertiary level ICU with all facilities, and out of 60 beds which I am running, if you look at one point of time, there is almost 50 patients who are referred from other hospitals. So initially they come from the either village or some other towns, smaller towns or the same town. They go to these small hospital first, and from a small hospitals they are referred to some corporate hospital, and from those corporate hospitals they are referred to our institutes. So you can imagine those patients who have received tons of antibiotics before coming to my ICU, what kind of infection they are carrying. So this is, I think, a very big problem as far as uh, knowledge part is concerned in the medical practitioners of our country. Why we increase resistance, why we increasing such kind of bugs, it is our own fault. It is not the fault of bug, it is our own fault. Our practice is bad. We do not have appropriate knowledge. And that is why we fail to manage such kind of cases in a proper way. We think that yes, recently I saw one patient who was just having a small respiratory tract infection. What I understand that it was probably a viral infection. He was given doripenem in one of the small hospital, and almost 10 vials of doripenem was given. And you can imagine that there is barely any penetration of doripenem in the chest. They are not knowing, just somebody must have come and told, a doripenem laga dena hai. So doripenem, 10 vials, after 10 vials of doripenem, he was referred to some corporate hospital. In corporate hospital, he was kept for 2 days, where he spent almost 1,20,000 rupees. And then they said, no, we don't have money, we cannot afford. Although their management line was okay, but the family member said, we do not have money, we want to go to government hospital. Then that patient came to my hospital. And when he came, I saw that it was just a simple streptococcal infection for which he was receiving doripenem. eh. So this is a big problem in our country, and it is not only, I say, one state, but across the country. If you say, if you have 1 lakh ICUs in our country, probably 90, 90 more than 95% of ICUs are facing this problem. More than 95%, because our practice pattern is bad. Knowledge is very poor. Referral pattern is bad. Why these patients are referred from when they are very sick? Why they are on deathbed? They are sent to the government sectors, because we are the hospitals who actually take the entire brunt of this kind of patients. So worst kind of patients comes to us, And reason is this. So India has got these are the basic problems in India.
Got it, sir. So, sir, coming to the empirical therapy decision making, in critically ill patients with suspected carbapenem-resistant infections, what are the best empirical treatment strategies before definitive susceptibility data are available?
No, again, as you cannot take a blind or any mathematical or an objective way of taking such kind of decision. Again, you have to see that what kind of setup you are working. In my hospital, again, if I see that a poor patient has come, and in my hospital the available molecule is colistin. We do not have ceftazimivactam. We do not have other higher antibiotics. So I have to rely on colistin, polymyxin. Huh? Sir. So whatever is available, because as per the order which we receive from our hospital authorities, that you should use those molecules which are available in the hospital, and if you feel that these molecules are not available, then you have to fill a restricted drug form, then it will go for purchase, but usually they take 4 to 5 days. So again, it is a long process. So that is why we start with colistin. Okay, give a loading dose of colistin or polymyxin, because these two are available. So this is just an example I am giving. So suppose if we have enough number of ceftazidime-avibactam, I'll be happy to use that. Then I would like to give more toxicity to the patient. I would like that, yes, the agent which has got the most best safety profile, I should use that agent. So if it is available in the hospital, I'll use that, because one vial of ceftazidime-avibactam nowadays, it has the cost has come down, and I think yours is one of the companies providing at a very cheap rate of this molecule. But still, affordability has to be seen. So you have to see the affordability of the patient. If the patient is affordable, no issues. You go ahead with ceftazidime-avibactam. If it is available in your hospital formulary, very nice, no problem. You can use imipenem-relibactam. You can use meropenem-beverobactam. You can use ceftazidime-avibactam. So all these things. These are the molecules which are there on pipeline, but very soon they are will be available in the market. So you have to see as an intensivist with the current, because time is very important in ICU. You cannot wait. Okay, I'm writing a restricted drug form, and it will go to our sister will take it to the store officer. A store officer will send to the medical superintendent. Medical superintendent will send to the accounts. Accounts will again approve it, and then it will be signed by director, and then it will come. So the whole process takes 3 to 4 days. So, and even if you have to wait for 6 hours, we cannot wait. No? So best thing is that whatever available thing. So I think it depends on the molecule which is readily available and which the patient can afford. Because on the one hand, polymyxin, colistin are considered as cheaper agent nowadays. On the other hand, ceftazidime-avibactam is a costlier but safer agent.
So basically, in India, you are saying it should not be objective basis.
Yes,
It has to be on a situational basis based on the availability of the medicine
definitely.
and the cost effectiveness to the patient.
Definitely. Again, I say ki another important thing, diagnostic facilities. How you are going to diagnose? Huh? So, how many hospitals they diagnose this year is? If you go to any big city, there will be one or two. Nowadays, this biofire has come, but biofire gives many false positive results. That is a big problem. So, colonizers are detected like anything. So that is also a problem. So, even if you see that yes, a good microbiology report is there, uh, and your hospital has got that capability to produce good microbiology report through like in my hospital we have NGS also. So if it cannot be detected by PCR, microarray system is there, and then NGS. Mildly off is another thing many hospital has got, but we do not have mildly off, but we have this NGS. So whenever we are in high confusion, we send it to our genetic lab, and they take some time, but they give the appropriate diagnosis. So that is another important thing. The how you can give empirical therapy for CRA? Can you give it? No, it is not. I don't see it is justified. Now another thing I am telling you, uh, we get lot of, as I said, 90% are referral patient in my hospital. Out of which 50% of the patients they get these ceftaroline or ceftazine avibactam outside. When they come to my hospital, because we have restricted formulary, so we run our formulation between meropenams, piperacillin, tazobactam, sulbactam, and this thing cholesterol, polymyxin. These are the and we give combinations. Different we make different kind of combinations, and we see that patient has recovered, no problem. So we have not seen that yes, eh, other than 1 or 2% cases, outcome is good. So many a times we think that how this ceftazine avibactam was started by a practitioner who is also a learned practitioner. I'm not saying anybody. How he has started that. So nowadays, what has happened that people have started using this drug empirically. That is bad. That is bad.
So, coming to the next important aspect of combination therapy versus monotherapy, what is the current evidence on combination therapy versus monotherapy for carbapenem-resistant infections? And are there specific pathogen drug combinations that have shown better clinical outcomes? As in, are there specific pathogens and or microbes and specific antimicrobials which have better efficacy?
No, obviously, the combination ceftazine-avibactam combination has been shown to be better as compared to monotherapy in the form of polymyxin or colistin. Whether you comparison has shown that it is non-inferior or it is better. So, uh, for these kind of organisms, if you ask me, carbapenem-resistant infections, Enterobacter or KPC, Klebsiella producing carbapenem resistant Enterobacter. So these for these organisms, I think a combination therapy is must, because monotherapy many a time it may or may not work, and it is very difficult to understand because if you say okay, the lab is giving polymyxin sensitive, now whatever thing we see in vitro, can it be replicated in vivo? So, studies which are done in laboratory as far as sensitivity and microbiological testing and other things are concerned, how much patients will be cured with the results which we are seeing or which is coming from the laboratory? Again, it is 50-50. The chances of cure is 50%. So, as a clinician, can I take that risk? Okay, if I'm using monotherapy, even if my 50% patient doesn't get cured, no problem. Can we take that risk? No, we cannot take that risk. So that is why I always say that your clinical decision is most important. You are not treating the investigation, you are treating your patient, and your patient has to be treated based on your clinical decision. You have given 5 days of ceftazidime avibactam, but still, because I remember one of my teacher, when I asked him what is the best test to say that patient is well or not, he said look test. What is look test? So you look at the patient's face, and his face will tell you that he is sick or not. No laboratory can give such kind of impression to you. No laboratory. So he categorically said, he is a very senior from Boston University, and he said it is look test which is the best test. So as I said, you give 5 days of ceftazidime avibactam, and you see the face of the patient and say that patient is still looking sick. So can you justify yourself that no, I'll continue giving ceftazidime avibactam, I'll not change. No. As a clinician, you can't do that. You have to immediately change your decision. You have to think about something else. It's already 5 days. No response to my patient. So this is how we should go ahead. Literature, you see, studies are done in very different conditions, and most of the infectious disease publication, these are all laboratory based. Maximum, what we read, what we apply, what we say, all laboratory based. But as I said, in my hospital, those patients who are receiving ceftazidime avibactam coming to my patient ICU and I am giving meropenem and is getting cured, that means what? Was he suffering from CRE infection or not suffering from CRE infection? Can you give an impression? Can you give an impression? Very difficult. So I see that clinical improvement, that probably their microbiologist might have said, oh, it is looking like a very bad kind of infection. It may be a KPC. You should be very alert. And now the clinician, without thinking, without waiting for the report, he has started empirically. नहीं, चालू कर दीजिए भाई, patient गड़बड़ हो जाएगा. So by the time he sees the result, and the patient got lama from his hospital and he came to some other hospital. So these are very common understanding and thought process which we should carry when we treat such kind of patients.
Okay, sir. So, sir, regarding novel and alternative agents, with new antimicrobials like cefiderocol being available, how should ICU physicians decide between traditional options like polymyxins and these newer agents?
Again the same thing. Cefiderocol. No, I know. Very soon we are going to get imipenem-relivectam and
Exactly.
meropenem-bevorobactam also has come very soon. Then we'll have 4, 5, 6 options for CREs. हैं? आप choose कर लीजिए कौन सा देना है. तो लग्जरी हो गया ना. अभी एक साल पहले कुछ नहीं था, हमारे पास लग्जरी है. Now we have 6 antibiotics. Again, I say that you should be very, very judicious when taking decision. Your thought process, your clinical knowledge is the one thing which makes the difference. Molecule 10 आ जाए. अब मैं अभी एक there was one case, young patient. um he got treated for initially some abdominal condition. Later on, he developed ARDS, and then ARDS recovered. Although patient was extubated from ventilator, everything was fine. But somehow his fever was not coming down. And every day used to say, I'm really afraid of this fever. What is happening? I don't know. So suddenly I thought, can it be because of too much of antibiotics which we are giving? Then what I did, I just stopped all the antibiotics. I said, ठीक है, just इसको augmentin कर दो, one antibiotic, augmentin, and rest all gorilla mycins were stopped. सारे बंद कर दिया, and you won't believe in next 24 hours his fever stopped. So this is another way of looking at patients. So you may have too many antibiotic use is also bad. Then another important concept which says that bactericidal or bacteristatic. Hmm.
Sir, I'll come to my last question for this session regarding stewardship and de-escalation approaches. How can ICU physicians integrate antimicrobial stewardship principles when treating carbapenem-resistant infections to balance efficacy, toxicity, and resistance prevention?
See, again I say stewardship. We talk a lot about stewardship, but we started doing workshop on stewardship. I think 10 years down the line. 10 साल पहले हमने start किया होगा. If you see today in our country, how many ICUs are following this stewardship? We just only talk. We don't follow. Um, so stewardship, again, I say, ki it is a very good thing. But again, who are supposed to implement? How to do that? And I mean to say, what are the ways to implement that? And do you think that your staffs have enough knowledge to do that? And outcome measures, if you do not show that yes, with the stewardship these things are happening. So overall, I say stewardship is very good concept. There is no doubt about it. But in India, hardly 1 or 2% hospitals are following this, and that too under the pressure of many, because NABH has started. Uh, you call it NABH has started asking for data of what you are doing for a stewardship, and all those are false data which are created by the hospital. 90% false data, what I know. So the data are created falsely. Anyway, but I must say that like your company, uh, you can take good initiative to implement stewardship programs. Um, like how you can do that? Because in stewardship, intervention is the most important part. Hmm. So, if I say one point is control your drug formulary. Hospital has got all different kind of staffs. Pharmacists are also there, but pharmacists do not know what is how to control the formulary. Huh? Now, what are the interventions which can be taught to those pharmacists so that they can do it on regular basis and they can collect data, and at the end of the month they are analyzed and the outcome is discussed among the stakeholders and then it is finally implemented. So safety, efficacy, resistance, safety profile is to something which we
Which is
cannot
taken.
uh, because it varies from patient to patient. It may be very safe for you, it may be unsafe for me. So it comes under now personalized medicine or precision medicine safety. Then you said resistance. Resistance, this is one way how we can prevent
Prevent resistance.
uh, unnecessary, inappropriate use of the drug and the resistance. We can cut it down a little bit. But there are other ways. I tell you, yesterday I was discussing with Bram Rochevaux. He is from McMaster University. He has come. He is intensivist. So I said, you know, Bram, in my hospital, I have 8:1 a patient nursing ratio. We have one nurse in 8 patients. Why? Because government hospital. So then he said, how you are managing this 60-bedded ICU? I said, I have got a huge pool of technicians. So I have 80 technicians. They are working as a student as well as means 3 batches stay at a time. One batch is first year, one batch is second year, and third batch is intern. So they learn all the tricks, ins and outs of all nursing and other things in 1 year, and rest 2 year they are our workforce. So at least 80 students are there, and day and night, because and we don't have to pay anything. Hmm. So I have put the nurses only for one thing, that is they will give the medications at right time. That is the only job of our nursing. Then who will take the laboratory sample? I have kept two pathology technician in every shift. So these pathology technicians, their job is to collect different kind of samples, take it to the laboratory and bring the report and attach to the file. Then I have kept one radiology technician in every shift. What is his job or her job? To do all the x-rays, to call the radiologists whenever required for ultrasound and other things, and get all the x-rays done. So no nursing involvement. Then who will check for the ventilator, who will check the syringe pumps, who will check the monitor and other things. All these things are done by technicians. Hmm. The only part which remains, that is the body bath and taking care of stool and urine, that is done by patient's family member. We allow family members inside ICU. One family member is allowed for this thing. Okay, but they don't stay for whole day. But when in the morning they'll come, stay there for 2 hours, do all the things because patient are ventilator. Suctioning is done by our technicians other. Now, what is the advantage? Suppose I leave a patient to nursing staffs. Nursing are doing all body bath and other things, take care of the body. Now, every shift there is a change in nursing staff. Now, suppose I am a patient, he is my family member, and he is taking care of me. My body colonizers are same what he is having. But if an outside nurse is taking care of me, his her body colonizers absolutely different. So when she touches my body at different places, what happens? Her colonizers, they come inside me and they behave like pathogen. So it is not one nurse. So in every day there are four nurses who are changing shifts, and every time they are coming and touching the body at different places. You're getting my point. So this is one hypothesis which I generated and I discussed with him. He said, okay, it is very interesting. I said, yes. And that is why probably in my ICU I do not get so much of CREs. Our incidence is very low. Hardly 10-12% we get CREs. We do not have CREs. Very less. I myself am surprised to see this thing, but yes, it is happening. You come and see, you will find that yes. So I thought, then he said, okay, if you feel that is, you can make a paper. I said, yes, but how can I prepare the control? I have to take one corporate hospital because in corporate hospital, every 1:1 nursing is there. So I have to compare 1:1 nursing and 8:1 nursing. Huh? You're getting my point. So things are highly variable, highly dynamic. Everything is changing day and night. Whenever you think it is totally upon the setup. So as it is said that every ICU should customize their need. Every ICU should customize the way they are managing the patient. Because why I took such kind of decision? Because as soon as I started, because the department was opening, a new department was opening, when I asked for nursing, they said, only can give you two nursing staffs. I said, how can I work with two nursing staff? They said, देख लो कैसे करोगे? तो दो मतलब मैक्सिमम 5 पेशेंट रखूंगा क्या? 5 पेशेंट में आईसीयू चलेगा? तो फिर देन आई हैड टू टेक ए डिसीजन. देन आई सेड कि ओके बेटर आई शुड यूज माय टेक्नीशियन. मैंने कहा मैं तो ट्रेनिंग दे करके किसी भी चीज को मोल्ड कर लो आज आप. ट्रेनिंग एक ऐसा चीज है कि आई थिंक वही सबसे ज्यादा लैकिंग है. ट्रेनिंग या टीचिंग सबसे ज्यादा लैकिंग है. मैं ग्रास कटर्स को चेंज कर देता था एनेस्थीसिया आईसीयू टेक्नीशियन में. मैंने ऑप्थेल्मिक टेक्नीशियंस एंड डेंटल टेक्नीशियंस, हमारे यहाँ जब कोविड हुआ था ना, तो कोविड में सारे वो डेंटल वाले टेक्नीशियन और ऑप्थेल्मिक टेक्नीशियंस को मैनिफोल्ड टेक्नीशियन बना दिया था। उनको मैनिफोल्ड का ट्रेनिंग दिया कि सिलेंडर कैसे भरा जाता है, सिलेंडर कैसे ढोते हैं, सिलेंडर कैसे कनेक्ट करते हैं, ऑक्सीजन सप्लाई कैसे होता है, प्रेशर कैसे चेक करते हैं, कौन सा वाल्व को कैसे चेक करना है, अलार्म आने पे क्या करना है। मैंने इतना ट्रेनिंग दिया उसको कि वो सारे ऑप्थेल्मिक टेक्नीशियन जो बन गए, वो 22 टेक्नीशियन थे, और वो 8-8 लड़कों को एक साथ लगाता था मैनिफोल्ड में। कितना फास्ट सिलेंडर चेंज हो रहा है, 100 बेड्स ऑन 100 पेशेंट्स ऑन वेंटिलेटर, यू कैन इमेजिन। सो आप चाहो जैसा चेंज कर लो। ये जो चलता है ना कंसेप्ट में, वेस्टर्न फॉलो करता है कि नहीं नहीं नर्स तो चाहिए, नर्स के बिना आईसीयू कैसे चलेगा, अरे नर्स के बिना आईसीयू नहीं चल सकता है। अरे मैंने कहा कैसे नहीं चल सकता है, सब चलेगा, कुछ नहीं चलेगा। और ये लड़के मेरे एकदम हनुमान टाइप काम करते हैं, दनादन, यहाँ से दौड़ा वहां, वहां से दौड़ा वहां। आप देखिए कुछ भी काम करके दिखा लीजिए, नर्सेस तो उनके सामने कहीं टिकती नहीं है। तो वो चीज आपको अपने हिसाब से कस्टमाइज कर लेना होता है, मुझे लगता है, डिपेंडिंग अपॉन योर सेटअप एंड डिपेंडिंग अपॉन द फैसिलिटीज विच हैज बीन प्रोवाइडेड टू यू। You are not the master, and ultimately the person who is under whom you are working, he is giving you the facilities which, so if he satisfies you, fine. If he fails, that you have to find your pathway. नहीं
So that's a really great experience, I think, because I personally feel your technician should get a nursing degree also.
अरे they are, you see what how I gave a lecture in Manipal hospital Bangalore. तो दे वर हाईली सरप्राइज, दे सेड कि सर आप ऐसा कैसे करते हैं। मैंने कहा देखो, इससे मैनेजमेंट को फायदा है। एक नर्स को आप हायर करने जाओ, दे चार्ज 30-40,000 रुपीज, और ये हमारे टेक्नीशियन 10-10 हज़ार में काम करते हैं मस्त। तुमने कहा एक 4 नर्स के कॉस्ट पे, एक नर्स के कॉस्ट पे आप 4 टेक्नीशियन रखते हैं। तो आपको एज ए क्लिनिशियन इफ यू सी, तो मैनेजमेंट को भी फायदा है ना, हॉस्पिटल के मालिक को भी फायदा है? नहीं So anyway, yeah, this is absolutely. I'm off the track. I'm not talking. This is not official, but uh, you see, whatever resources you have in the form of manpower, instrument, gadgets, or whatever, if you, as an in charge of intensive care unit, if you have a good knowledge, you can customize everything as per your requirement.
Sure, sir.
So that is the crux of everything. देखिए, it is very easy to say, अरे उस पर झाड़ू नहीं लगा रहा इसलिए इन्फेक्शन बढ़ रहा है, अरे लोग जूता पहन के घुस जा रहे हैं इसलिए इन्फेक्शन हो रहा है। ब्लेम करना बहुत आसान है। मैंने कहा मेरे आईसीयू में तो सब जूते ही पहन के घुसते हैं, हम तो कोई रोकता ही नहीं है। मैंने कहा कहाँ लिखा है कि नो, इट इज 0.1%, 0.1%। जूतों के साथ लोग हंगामा करते हैं, बट ठीक है, हमारे यहाँ वो क्या है, गंदगी दिखना नहीं चाहिए, है ना। तो वो जो स्वाइलिंग होता है उसकी वजह से प्रॉब्लम है, गंदगी करके चले। अदरवाइज एज सच इट डजंट क्रिएट प्रॉब्लम टू द पेशेंट्स। तो हमारे यहाँ वही हो ना कि वी डोंट डेवलप आवर ओन कंसेप्ट, वी आर फॉलोअर्स। वेस्टर्न वर्ल्ड ने बोल दिया, अरे बड़ी बात हो गई। हम तो, मैं बिल्कुल नहीं विश्वास करता हूँ, क्योंकि I see these things from मैंने with a very close eyes, and I have seen that how the guidelines and other things are generated. वो खुद ही अपने बनाते गाइडलाइन, खुद नहीं फॉलो करते हैं हम, ये भी बात है। हाँ,
Yes.
तो दुनिया को बोलेंगे फॉलो कीजिए, हम नहीं। तो थिंग्स आर वेरी डिफरेंट फ्रॉम, तो मैं ये कहता हूँ कि इट इज द इंचार्ज or the person who is the main in charge as an intensivist, or those, suppose there is a team, it is their knowledge which decides for everything. Everything is dynamic, nothing is static, and there is no fixed formula for anything.
Nothing is objective, everything is subjective.
Yes, subjective plus there is no fixed formula, I'm saying. No fixed formula for anything. Treating an infection is also an art. It is also an art. कि बुक ने लिखा है कि यार 6 दिन देना। एंटी फंगल में मैं बता रहा हूँ, हर जगह लिखा रहता है कि जिस दिन कल्चर नेगेटिव आता है उसके बाद आपको मिनिमम 14 डेज देना है ना। हमारे तो 10 दिन नहीं अफोर्ड कर पाते हैं, अब फिर ठीक होके चले जाते हैं घर। हाउ इट इज हैपनिंग? हम तो 10 दिन ही देते हैं, वोरिकोनाजोल भी दिया 10 दिन, और जबकि प्रूवन दिख रहा है कि हाँ भैया है, तो भी तो 10 दिन बढ़िया ठीक ठाक होकर घर चले जाते हैं उसका। यू गेटिंग माई पॉइंट? सो थिंग्स आर डायनेमिक। मैं आप यू हैव टू सी कि एग्जैक्टली व्हाट पेशेंट नीड्स एंड ट्रीट द पेशेंट, नॉट द टेस्ट। एक्सरे में दिख रहा है सफेद, हमने कहा कि देखो सैचुरेशन पूरा वाइट दिख रहा है, हमने कहा सैचुरेशन देखो, सैचुरेशन बढ़िया है 98 99 है।